In this video, we're going to go over hypertension. We're going to talk about the pathophysiology, the causes, and then go over the newly updated 2025 AHA guidelines and recommendations. So starting with the pathophysiology of hypertension, we need to understand how the body regulates blood pressure. So there's a formula that you need to know, which is blood pressure equals cardiac output times systemic vascular resistance. So both cardiac output and systemic vascular resistance play a huge role in determining whether a blood pressure is going to be elevated or not. Cardiac output is the amount of blood pumped out by the heart in 1 minute. And then cardiac output has its own formula as well. So cardiac output equals stroke volume, which is the amount of blood ejected with each beat times heart rate. So all of those factors, cardiac output, stroke volume, and heart rate, all play a factor into blood pressure. Systemic vascular resistance is the body's resistance to blood flow, or essentially how hard the heart has to pump to overcome the resistance of the vessels. This most commonly is going to be affected by the size or the diameter of the blood vessel as well as the blood viscosity. So whether there is vasoconstriction or vasodilation will deeply affect how the blood pressure looks. So there are two main hemodynamic aspects that you need to understand whenever it comes to blood pressure. So the first one is what happens as soon as blood pressure changes are detected. So it happens within the first couple seconds to minutes of blood pressure changes. So these changes are detected by baroreceptors that are found in the aortic sinus and the carotid sinus. Baroreceptors are activated by the stretching of the vessels related to high pressures. So, higher blood pressures causes an increased stretch in the vessels that stimulates baroreceptors. So, when there is lower pressure, there is less stimulation to the baroreceptors, meaning there is less baroreceptor firing. This causes an increase in the SNS stimulation and decrease in the PNS stimulation, which then causes an increase in heart rate, an increase in contractility through vasoconstriction, and an increase in blood pressure. Now it's going to be the opposite for higher pressure. So higher pressure means more baroreceptor firing because we have more stretch on those vessels, which stimulates those baroreceptors. This causes a decrease in SNS stimulation, an increase in PNS stimulation, which causes a decreased heart rate and decreased contractility, which causes vasodilation instead of vasoconstriction, and therefore decreases the blood pressure. Now, the second hemodynamic aspect that you need to understand is the renin angiotensin aldosterone system. This is typically a little more long term and happens over minutes to hours from blood pressure change. So the kidneys detect that there is decreased renal perfusion and it stimulates the renin angiotensin aldosterone system. Low blood pressure stimulates the juxtaglomerular cells of the kidneys to secrete renin. Renin then goes to convert angiotensinogen to angiotensin 1. Angiotensin converting enzyme is then used to convert angiotensin 1 into angiotensin 2, which is what is important here for that blood pressure regulation. Angiotensin 2 causes vasoconstriction, aldosterone release, and aldosterone is used to stimulate sodium and water retention, and then ADH release, or antidiuretic hormone, which we want in order to be able to hold on to more water. So the goal of this entire system is to increase the blood volume and increase systemic vascular resistance. Remember that blood pressure equals cardiac output. So by having an increased blood volume, we're increasing cardiac output times systemic vascular resistance, and we're increasing that as well through vasoconstriction, which will help to raise blood pressure. Now, the different causes or types of blood pressure include primary, which is the most common form of hypertension, also known as essential hypertension, and it has no identifiable cause. Secondary hypertension is caused by anything that increases systemic vascular resistance, blood volume, or increases cardiac output. Some common causes are kidney disease, hyperthyroidism, adrenal disorders, coarctation of the aorta, pregnancy because of that increased blood volume, sympathomimetic drugs, and sleep apnea. The other one that you'll want to kind of have in the back of your head is isolated systolic hypertension. This is elevated systolic blood pressure without elevated diastolic blood pressure, and it's more common in elderly due to their stiffened arteries. Okay, let's go over some of the new 2025 American Heart Association guidelines and talk about what's different. So, diagnosis and grading is the same as before. So, diagnosis requires two separate readings on two separate occasions. So, if you have a patient come into the office and they have elevated blood pressure in the office that day, it's not recommended to diagnose them with hypertension solely based off that one reading. What I personally like to do is provide my patients with a blood pressure log, send them home, and have them take their blood pressure twice a day for the next 2 weeks and then return to the office with the log so I can get a better idea of what their blood pressure readings are at home. This helps to rule out white coat hypertension. There are three different stages that you need to know. First one is elevated. This is a systolic blood pressure of 120 to 129 and a diastolic blood pressure greater than 80. Stage 1 is a systolic of 130 to 139 or a diastolic of 80 to 89. So if a patient consistently has a blood pressure of 125 over 85, that would still be considered stage 1 hypertension because it doesn't have to be elevated systolic and elevated diastolic. It has to be one or the other. Lastly, stage 2, this is a systolic of 140 or greater or a diastolic of 90 or greater. So same thing. Doesn't have to be both elevated systolic and elevated diastolic. It has to at least be one of them. So, the guidelines as far as when to treat patients with hypertension have changed slightly with the new 2025 guidelines. So, let's kind of go over those. So, for those with stage 1 hypertension, the recommendation is to initiate medications for anyone who has cardiovascular disease, diabetes, chronic kidney disease, or, and this is where the big change is, a 10-year CVD risk score of greater than 7.5% using the PREVENT calculator. The biggest change here from the 2019 guidelines is that they are now wanting you to use the PREVENT calculator to calculate the CVD risk rather than the ASCVD risk score. If a patient has stage 1 hypertension, but they do not have any of these comorbidities and they do not have a 10-year CVD risk score of greater than or equal to 7.5%, the recommendation would be to do lifestyle intervention for 3 to 6 months. If they do not see improvement in their blood pressure after those 3 to 6 months, then it would be recommended to initiate medications at that time. The recommendation for stage 2 is to initiate medications for everyone who's diagnosed with stage 2 hypertension, regardless of comorbidities. First-line medication recommendations for hypertension fall into three categories. The first one being ACE inhibitors or ARBs, which we are not recommending for African American patients due to the increased risk of angioedema. The second ones are DHP calcium channel blockers, and then the third one is thiazide diuretics. For stage 1, the recommendation is to start with a single agent and then titrate accordingly. For stage 2, the recommendation is to start with two first-line agents of different classes. So maybe like an ACE inhibitor and a thiazide diuretic, or an ARB and a calcium channel blocker, preferably in a combo pill in order to prevent pill burden and increase the patient's adherence to the medication regimen. Some other recommendations made by the AHA in order to help reduce hypertension include weight loss. So they recommend a 5% weight reduction for patients who are either overweight or obese. They recommend limited alcohol. So safe drinking limits, according to the AHA, are for women 1 drink per day or 7 drinks per week, and for men 2 drinks per day or 14 drinks per week. They also recommend to increase dietary potassium intake, except for patients with chronic kidney disease or patients who are on hypertensive medications or other medications that have hyperkalemia as a risk, such as ACE inhibitors, ARBs, and spironolactone. They also recommend a low sodium diet, such as the DASH diet, which typically has a sodium limit of 2.3 grams per day. However, they did add that ideally these patients would have 1.5 grams or less per day of sodium. Exercise recommendations is 150 minutes of aerobic exercise weekly, and then they recommend stress reduction and have some examples of how to do so, such as meditation and yoga. Some management points that you need to remember are: 1, when do we screen for secondary hypertension? So the recommendation is to screen for primary aldosteronism using the aldosterone-renin ratio, and this is for all patients with resistant hypertension, hypokalemia, sleep apnea, and adrenal mass, or a family history of early onset hypertension, which would be less than 40 years old, And then you should consider screening anyone who is diagnosed with stage 2 hypertension. Monitoring includes monitoring of the kidneys and the eyes, most importantly, because hypertension can put a strain on both of those. So we monitor the kidneys through an annual microalbumin creatinine ratio and EGFR. The microalbumin creatinine ratio is a very early indicator of kidney disease, and you will see elevations in that before you are likely to see a decrease in your EGFR. And lastly, we recommend annual eye exams to assess for any changes behind the eye due to increased blood pressure.